All right. Thank you, Bill, for that warm introduction. And good afternoon to all of those that have joined. Thank you for joining our webinar. Here to give my perspective on management of low back pain and see how I can help treat your patients and get them back to where they want to be as soon as possible. So a little bit about myself. I'm born and raised here in the northwest suburbs of Chicago. I went to medical school down in St. Louis for 4 years, and then went out to Pittsburgh, where I did an anesthesia residency, and then came back home for my fellowship at Rush for interventional pain management, and soon thereafter have joined Ortho Illinois. And so I'm happy to be back home, happy to be taking care of the community that I was born and raised in, and looking forward to providing my skill set to the patients in and around the area. Before we start, I just wanted to go over a little bit of my practice philosophy. Obviously, every physician has a different philosophy in how they approach their patient encounters and how they evaluate various etiologies. But for me, the biggest things that are important is really to take time to listen to the patient and determine what has happened, how did they injure themselves, try to pick up on some key details that can give me some insight as to why they're having the symptoms that they are, and then really spend some time talking to the patient and encouraging them to utilize some of the conservative measures such as physical therapy, acupuncture, chiropractic care, and we'll talk about that more in detail, and pairing it with some multimodal analgesia. I'm a big believer of using medications in various classes to help get pain control, and not really relying on narcotics unless absolutely necessary. And the whole goal is to really try to improve the function of the patient, get them back to where they want to be as soon as possible, utilizing interventional pain procedures to speed up that recovery, and encouraging patients to take time to understand what is happening, ask questions, take time to answer those questions. And the last 2 points at the bottom of the screen are really the main points I wanted to get across here, which is, for me, it's most important to be honest, have integrity, try to develop that trust with the patient and or their family members that are there for the visit, caseworkers, etc., and respect the patient's decision. At the end of the day, we all will give our opinions. Patients have their own opinions, and we try to come to a middle ground. But it's the patient, it's their body. They're the ones that are dealing with the symptoms, and so give them all the ability to make that decision and help them doing so, and treating them as if they're my family member. What would be my recommendation if this was my mom, my sister, etc.? So a little bit about low back pain. The reason I chose to talk about this is that it is a very common thing that many people experience and many physicians see. It's the leading cause of disability worldwide. In the United States, it's the most common reason for lost productivity at work, the most common reason for worker compensation claims, as many of you, I'm sure, are aware of experience. And approximately 50% of adults at some point in their life will have low back pain that's severe enough that has required an emergency room visit, primary care appointment, or an appointment with a surgeon. Not only that, but it impacts our economy. So in 2011, there was $14.2 billion worth of work-related overexertion events. On a year-to-year basis, there's $100 billion spent on management of low back pain, which is quite a bit of healthcare expenditure. And a lot of this cost is coming from treatment, but then also lost wages from downtime at work, disability benefits, litigation fees. And these costs are just rising as years go on for many reasons. Litigation expenses have gone up, disability benefits are increasing. And then not only that, but pain physicians and the industry has developed newer techniques and newer modalities to treat various conditions, and so some of the treatment costs have increased thereafter. So specifically, how does low back pain impact workman compensation claims? So I looked into this from my experience, as well as what the literature has shown, and approximately 50% of MSK injuries and illnesses result in disability. Now, for the most part, people go back to work within 7 days, but we're all aware of managing those patients that have been off of work for 2 weeks, a month, and it just continues to linger because they don't get back to where they were pre-injury. significant component of this is not just the physical injury or the anatomy or physiology of what's going on, but a psychosocial element. And a lot of it has to depend on how the patient feels in their work environment, and whether they want to return to work or not has a big role in whether they will do that sooner rather than later. There are certain professions where low back pain has a higher prevalence. Nursing aides that have to lift patients or move heavier objects back and forth, attendants, heavy labor industries, janitors, cleaners, truck drivers, etc. Those are some of the more common professions that typically will experience low back pain or low back complaints. And some of the risk factors to look at are, what kind of things are in place at their work? Is it a heavy physical demanding job? Do they have any ability to modify their work? If so, they're more likely to return to work faster. Do they have any expectation of their return to work? Fear of re-injury. So I take care of many patients that do work in this heavy, labor demand type of activity, and they're very afraid that they get back to a point where they can take care of themselves at a home, doing light activity, but they're worried that the minute they go back, they won't be able to do the things that they need to from a work standpoint. There are, of course, other risk factors pertinent to the patient themselves, those that are smokers, obese, peripheral vascular disease. These are just some things that kind of will put patients at a higher risk of developing low back pain, but just other things to keep in mind. So the key thing that I wanted to get across is low back pain is very difficult to treat. And why is that the case? Well, because low back pain has many causes. There's very rare instances where there's one etiology that can explain all of the symptoms that patients are coming in for. Physical exam findings, of course, help. Imaging findings will help, but they can't always pinpoint the precise source of the pain. And we have to involve the fact that relief from low back pain involves patient's effort, compliance with the treatment plan, as well as just time for the body to heal. And the last piece is something that I think a lot of times is lost when we're taking care of our patients, because everyone wants results very, very quickly. On the grand scale, approximately 2/3 of patients who have low back pain as a result of a work-related injury will return to work within a month. Another fifth of patients will come back within 6 months, and then the remainder will return to work after 6 months. But the longer a patient is disabled or completely off of work, the higher chance that they're going to file for permanent disability. And that's our goal, is to try to really prevent patients from getting into that zone. Some key definitions and anatomy here to come. What is the definition of acute back pain? So acute back pain is typically something that will resolve on its own and is present for less than 4 weeks. Things that will typically be treated with activity modifications, over-the-counter pain medications, maybe a steroid pack, short course of physical therapy. Subacute, these are things where patients may have had a history of a disc herniation or facet inflammation. They were prone to having back pain and then had an acute injury, just will take a little longer to recover. Chronic back pain is officially defined as pain that has been ongoing for greater than 3 months. And this is the type of pain that is either recurrent or very treatment resistant, and where a lot of the interventions are necessary. So quick anatomy of the lumbar spine. So if you're ever in an office visit with a pain physician and they're talking about x-ray imaging or just mentioning different things, this is kind of what we're looking at. So for your low back, your lumbar spine, you have 5 vertebrae. Each of these have a vertebral body and an arch, which I'll show you. And in between that, there are intervertebral discs, which act as the cushion for our lumbar spine. And so like I said, majority of the patients will have these 5 lumbar vertebrae, which are highlighted here, and in between that are the intervertebral discs. The back end of the vertebral body here is the pedicle. So that is this point that's highlighted here in pink that attaches to the back end that's really encasing and completing off the spinal cord and keeping it nice and intact. The lamina is something that you'll see is something that's providing support more from the side. You have a transverse process on each side, and the lamina is what's connecting that pedicle to the spinous process. And the spinous process is typically what you'll feel if you ever examine anyone's back, the bony processes that you feel in their back, those are the spinous processes. Now, like I said, we had 5 vertebral bodies, and so each of these vertebral bodies are connected to one another by facet joints. And these are the things that help connect the various levels together and allow for the spine to have the mobility and the range of motion that it can have. Each of these facet joints have their own innervation. There's typically 2 small nerves that come off and provide sensation to the joints themselves, and those are the nerves that we are typically going after when we're dealing with people who have pain from their facet joints or inflammatory conditions. And this is just a quick picture to show how these medial branches are present to innervate these facet joints. So like I mentioned, each facet joint has innervation from 2 different medial branches, one from the level that it's at and one from the level above where it's at. So in order to fully treat one facet joint, you typically need to block 2 different nerves to get there. So when a patient shows up for an evaluation here in our office, the things that we look at is to get a detailed history. What has happened? How long has it been since your injury? Can you give us other details of an accident? What has happened immediately after? How soon after the injury did you have symptoms and where that pain is? The other important things to delineate is what type of pain the patient has. That gives us somewhat of an idea if this is something that's more bone-related, more nerve-related, more muscular in nature, and what kind of things make that pain better or worse. Of course, we want to make sure that we're ruling out any severe findings, so constitutional symptoms such as fevers, chills, weight loss, the red flag symptoms that would likely cause us to have concern that the patient needs treatment much sooner, such as cauda equina, bowel bladder incontinence, things that we'll go over here in a second. And then trying to understand what has been done thus far. So many patients will have had some sort of treatment, whether it's medications, physical therapy, and what kind of relief they have gotten from those. That gives us an idea of what we can go next to get them moving in the right direction. And the last question I typically like to ask patients is that how is this injury or the disability impacting their ability to function whether it's at home or at work? Because it's at times very difficult to completely eliminate low back pain. But if you have an idea of where the patient wants to go or what they were able to do before, then you have a good idea what your endpoint in your treatment is. And it's important to kind of keep that in mind as you're recommending various interventions. Of course, once you have a detailed history, the next step is to get a focused physical exam. You want to look at the range of motion of their lumbar spine, having them do flexion, extension, lateral rotation. You want to take a look to see if there's any significant point tenderness of their spinous process, their paraspinal muscles, other joints that are in and around your lumbar spine. You do a good examination of their strength, sensation, reflexes to take a look at their neurology and their how intact their spinal cord and sensation is. And then there's certain provocative maneuvers that you can do to test for various pieces of suspicion. So if you're concerned that this may be more radiculopathy from a disc herniation or nerve root compression, you can do a straight leg raise test. If you're thinking the pain is more coming from facet joints, you can have them do axial loading maneuvers. And then there's various methods of assessing the SI joint, which is where your lumbar spine meets your hip joint posteriorly. And oftentimes it's a very close mimicker of low back pain, but very often overlooked. So I mentioned some red flag symptoms early on, but let's dive into that in a little bit more detail. So some of the things that definitely cause for concern are if patients are presenting with symptoms of fever, chills, weight loss. If they're young, you have to think about congenital or developmental anomalies. If they're older, you want to take a look to see if there's any history of cancer, fractures, other types of infection, because these things you want to have addressed and evaluated sooner rather than later. The key thing you definitely do not want to miss is cauda equina syndrome. And so this is when you have an acute compression of your spinal cord. can often be caused from a hematoma, an epidural abscess, or an infection of other kinds. Typically, you would have saddle anesthesia, which means you would have no sensation to light touch in and around your pelvis. You have very limited sensation in your lower extremities. You would have you'd have urinary retention, and typically the treatment for this is urgent surgical decompression. So this is one of those things you do not want to miss, because you need them to be evaluated sooner and get into the hands of a surgeon as soon as possible. But outside of that, if you have any other patient that's coming in for low back pain, there's various ways of assessing that patient from a diagnostic standpoint. Typical things, of course, first round x-ray just shows you the anatomy, if there's any fractures, transitional anatomy, if there's any shifts of those vertebral bodies. The key thing with an x-ray is that you can't specifically identify any soft tissue abnormality, so you can't determine anything about the discs, the nerves, the facet joints in that much detail. But it's a good first initial round of evaluation. Now, moving from that, typically pain physicians or surgeons are likely going to want more advanced imaging, and the two main options here are a CT scan and an MRI. From my perspective, an MRI is probably the best next most advanced study, and the reason for that is that it gives you a good clear look at the nerve roots, the discs, any scar tissue. However, there are some patients that may not be candidates to get an MRI, maybe from other hardware that's in place, pacemakers, etc. Or if you're really just concerned that it's maybe more of a fracture or a bone fragment issue, then a CT can help you because that looks more at bone structures in detail. The last two things I mentioned here are things that sometimes are part of your workup. If you've looked at everything else, maybe you've done some procedures and you're not making any headway, you can do a nerve conduction study or test the muscle function, typically done by physiatrists or neurologists, to take a look to see whether you're truly dealing with radiculopathy or peripheral neuropathy. However, it's not something that has been very sensitive to provide much information. So it's one of those studies that you keep in your back pocket if you're just not making any headway. And then lab testing, of course, if you're concerned about infection, cancer, or any other rheumatological diseases. One of the things we have here at Ortho Illinois is we have some rheumatologists that work here, especially in our facility, and so I often will consult with them if I am concerned for some other major rheumatological condition that could be explaining the symptoms that patients are having. So we'll do a quick dive on various etiologies. Of course, by no means is this list exhaustive, but it does cover a majority of the diagnoses that patients will come in that will lead to low back pain. And we'll kind of go through these line by line and give a quick summary of what it is. So musculoskeletal sprain or strain. So this is the most common diagnosis of low back pain, especially if a work-related injury. I'm sure most of us have had this at one point or another in our life. This is the typical, I went to go down, pick up an object, felt a sharp pain in my back, and I'm having really sharp pain for 7 days, 10 days, and it's slowly getting better with some conservative management. Like I said, typically resolves in 4 to 12 weeks. The first 1 to 2 weeks of that is the most acute period of time where pain is very severe. Often it becomes more of a dull aching sensation because it's majority related to the musculature in our lumbar spine. And it often will improve with activity with conservative management such as ice and heat, Tylenol, anti-inflammatories. Disc herniation is probably the next most common thing that we see. So like I mentioned, you have discs that are in between each of your vertebral bodies. They're supposed to provide the cushion between these bones so that your spinal cord and everything, all the other neural structures have space to exist. As we all age, our spine will degenerate, and you can have some weakening of the area that's supposed to encase that disc. That's called the annulus fibrosis. And when you have weakening of that, you can have extrusion or expulsion of some of that disc content, and that's what we would call as a bulging disc. If it significantly herniates, so that there's a significant component of that disc that has come out either centrally where the spinal cord is or laterally where the nerve roots are, that is called a disc herniation. This can lead to numbness, tingling, burning sensation along the dermatomal distribution, depending on the nerves that are impacted. And the reason for this is that when you have discs or any other content that touches upon your spinal cord or the peripheral nerves, these are structures that don't typically like to be touched or be close to any other structure. And so they will develop their own level of inflammation at the nerve level. And that is what causes the numbness, tingling, and burning sensation that patients experience. Now, very closely related to this is a diagnosis of foraminal stenosis. So this is when you can either have a disc herniation that instead of coming out more centrally has come out more towards one side or the other in the lateral recess where the nerve roots are actually exiting the spine or spine column. Sometimes it could also be due to bone spurs or what we would call as osteophyte complexes. So that's anything that will narrow that space as the nerve is trying to exit your vertebral column. And again, the symptoms are largely the same: numbness, tingling, and it's usually more along various dermatomal distributions based on the nerves that are being impacted. Just another quick look at foraminal stenosis. So, the picture on the left is a sagittal view looking at the spine, where the top of the picture is the head, the bottom is the foot. On the left is the front of the body, the right is the back of the body, and you can see where the arrow is pointing that you have a disc that's pushed out. What you can't see on that is whether that disc is coming out centrally or more off to one side or the other. The picture on the right is the same MRI, but an axial cut, so going across the body. On here, the orientation is flipped, so the left side of the image is actually the right side for the patient. The right side of the image is the left side of the patient. It's kind of like as if the patient is laying on a table and you're looking at them from their feet towards their head. And you can see that that disc has pushed out, but it's actually impacting more of that left nerve root than the right nerve root. And so this is an evidence of what we would call foraminal stenosis. Now, very closely linked to that is spinal stenosis. So this is where you have compression of the actual spinal cord centrally. And this can be due to discs that have herniated, sometimes also the ligament, which is a thick layer that's protecting the spinal cord from the posterior aspect, that can inflame, or what we would say develops hypertrophy or thicken, and that can cause compression from the back end. But nonetheless, at the crux of it, your spinal cord is being compressed. And when that happens, it leads to weakness, leads to loss of sensation. These are patients where they will complain of back pain that typically is worse when they're walking longer distances. They will feel cramping, aching sensation in their legs. Oftentimes, they feel like they have to lean forward, and that provides some relief. Shopping cart syndrome is one of the things that is typically things that we will look for, where they say, when I'm walking in a grocery store, when I lean forward, I'm able to move or ambulate better. And the reason for that is that that's our spine's natural way of trying to open up that space. The other common etiology of low back pain is facet joint arthropathy. So like I mentioned, these are the joints that help interlock the different layers of our spine. Just like we have joints, our hands, our wrists, our knees, these are joints in the spine that can also develop inflammation. Typically, when you have facet joint arthropathy related pain, this is pain that's more localized in the lower back. It's a dull, aching sensation, but can become sharp depending on activities. Often associated with morning stiffness that gets a little bit better as the day goes on. Now, of course, this pain can also be referred, so it's not just going to be in the back. Oftentimes, people will have the pain felt in the posterior buttock, lateral thigh, anterior groin. The big thing about this type of symptomology is that it typically will not lead to pain going down into the legs, all the way down into the foot or ankle. It won't typically lead to numbness, burning, tingling. So it's more of a sharp, aching, dull type pain. Key maneuvers that make this pain worse is if they are bending, twisting, sitting or standing for long periods of time, because that just causes stiffness of those muscles and the joints right in and around that. And if the inflammation is really severe, you can actually develop a facet effusion, which is that light gray line here in the image, because the inflammation has become more severe. Just a quick depiction, facet-related pain can be referred, and so you have to kind of keep this in your mind when patients are coming in and describing pain in various areas, because it may be coming from the facet joints and not some other source. Just another depiction of some of the areas where that pain can radiate. Now, just wanted to go over another quick piece of advice on if you're ever looking at X-ray or MRI reports, these terms are often listed, and what is the difference between any of these words? So you have spondylosis versus spondylolysis versus spondylolisthesis. They all seem very similar on the 30,000 foot overview, but they're very different if you actually look at what it is. So spondylosis is actually more what we call facet arthropathy or degeneration of the spine. Spondylolysis is when you actually have a fracture of the part. So it's a part of that pedicle lamina piece that has caused, there's a micro fracture, and the spine still stays very stable, but there is a break there. Now, over time, if you continue to stress that joint, that can actually cause translation of the spine itself, and that's where you have spondylolisthesis. So you have sliding of that vertebra. And if you have inflammation that's caused by this whole process, that's called spondylitis. And so like I mentioned just earlier, spondylosis is quote unquote arthritis of the spine, is degeneration of the spine. Many patients will develop this over the course of their lifetime. Spondylolysis is something that's a little bit more of an acute injury from stress or work or some work-related event. Now, there's other things that can increase the risk of having low back pain. You have things like scoliosis, so an altered curvature of the spine. This can cause disc herniation, facet joint pain, nerve root pain, any of the other things we've talked about thus far, because the entire body's weight is not distributed evenly as it was meant to, because the spine has an altered structure. You're going to have compression of nerve roots. Your discs are not aligned as they should be. The muscles have, had to correspond and try to support the body structure in some way. Your sacroiliac joints, which are where that spine is meeting the posterior hip, sometimes takes a brunt because the spine isn't perfectly aligned. Good segue here into what sacroiliac joint dysfunction, just like I mentioned. Oftentimes, when people come in for low back pain, it's very common to just look at the lumbar spine, and people forget about the sacroiliac joint. This is pain that's more in the buttock. It's often worse going in, changing position from sitting to standing, climbing stairs, getting in and out of a car. You're really stressing that joint out at that time. Now, it can lead to stiffness in the lower back. Sometimes you'll have some pain going into the legs as well. So it's a very close mimicker of a lot of the symptoms that you have when you have low back pain, but it's just the source of it is different. And so you have to kind of keep this in the back of your mind if some of your initial interventions are not working, that the patient may be having some inflammation or sacroiliac joint dysfunction. And like I mentioned, that pain can be felt in many areas. Posterior hip, posterior buttock is the most common area, but sometimes lateral thigh, lateral aspect of the lower leg can be some common referred places for sacroiliac joint dysfunction. Some of the rare things that you'll see, vertebral body compression fractures. This is more so with patients that are higher risk with osteoporosis, osteopenia. If they've fallen or had a significant hit to their back, sometimes they could have fractures of the vertebral bodies themselves, and that can cause more acute focal pain. Fairly often is treated conservatively, but sometimes if it's a significant compression fracture impacting your spinal cord, you may need to have surgery to treat this quicker. Various types of spinal fractures, compression, wedge, or burst, just depends on what kind of fracture you have. Often, like I said, treated conservatively, sometimes with the brace for 4 to 8 weeks or longer. If you have significant weakness or impact of the spinal cord or nerve roots, that's when you typically will need some sort of surgical intervention. So some of the other things that we see, post-laminectomy syndrome, this may not be something directly as a result of a work-related injury, but if someone has already had spine surgery and then has an injury or has ongoing pain, this is what we would call post-laminectomy syndrome. Up to 40% of back surgeries can quote unquote fail. And what I mean by that is that patients have had pain, they have surgery, they have some resolution of their symptoms for some period of time, and then the pain comes back or it never fully went away. And this can be due to scar tissue. If you have adjacent segments that haven't been operated on, those segments typically take more of a load and can develop disc herniations, facet inflammation, or just the hardware itself. It's often felt in the lower back and or lower extremities. The pain can be numbness, tingling, burning, sharp aching pain. It kind of mimics and has components of all the different things that we've talked about thus far. And often this is a diagnosis I'll consider if patients have pain present 6 months or beyond after surgery. Depending on the levels that are fused, you can have some sacroiliac joint dysfunction as well. And a couple things that I really like this image here. It kind of gives you a good idea of what to think about. So failed back surgery syndrome, or the same thing as post-laminectomy syndrome. Patients can come in with just leg pain, just back pain, or both, with a predominance of one over the other. And so, there's a lot of different ways to treat this. You just have to try to look at what are the symptoms that are impacting the patient the most. This is just a quick summary slide. I think Bill has mentioned that our slides will be available for patients or for all of you to review in the future, so you can take a look. It just kind of goes over all the different things that we just went over as etiologies of low back pain all on one picture. So let's talk a little bit about treatment and how I approach anybody that comes in and is complaining of low back pain. So I really try to stress and get as much out of conservative management as possible. That includes rest, ice and heat, activity modification, doing physical therapy, which, at least for 4 to 6 weeks initially, and you can pair that with chiropractic care or acupuncture. But I do mention that chiropractic care and acupuncture have very low evidence. And so, some patients will have sought consultation by these specialists and may have some relief, but it typically does not lead to any significant outcomes in the future. But it's, of course, a good adjunct treatment if patients are getting relief from it. But the best way to treat patients with low back pain is to pair conservative management with multimodal analgesia. And what do I mean by that? So whenever you're looking at medications to treat any condition, there's various receptors that you want to target. Acetaminophen is by far the best pain medication you can take for really any condition you have at all. It's been shown to be the best thing preoperatively, postoperatively, as well as for an acute injury. You can pair it with anti-inflammatories, which is great for patients who have pain coming from inflammation, acute fracture, and acute injury. You have to be careful on patients who have underlying renal dysfunction because you don't want them to be on these medications for long term. But for a short course, it's perfectly reasonable. And then the best way to utilize this, and I get this question a lot by patients, is they're usually either just using Tylenol or just using anti-inflammatories, but actually they both have a different mechanism of action. So to get the best mileage out of these two medications, you actually want to use them at the same time, but in intermittent fashion, so that your body is being exposed to medications that have a different mechanism every few hours. Now, you can pair this with some of the other medications. So you have steroids, which are great for initial reduction in inflammation, but do impact all your organ systems. So you don't want to expose patients to oral steroids consistently. I'm a big believer of muscle relaxants, and I tell patients all the time that muscle relaxants themselves are not pain relievers, but many times our muscles are inflamed or have spasmed and contribute to pain in a different way. And so muscle relaxant can help alleviate some of the symptoms that you are experiencing, but it may not be taking away the pain from the crux of the issue. Neuropathic agents are great to treat some of the conditions where you have had spinal cord inflammation or nerve root inflammation or compression. And I'm very big on getting patients on these medications sooner rather than later. Opioids have a role. They're helpful in treatment for acute low back pain if you've had surgery or something very acutely, but this is meant to help treat very short term, first 7 days, 10 days, really nothing beyond that unless you have some very identifiable cause of what's going on. Because oftentimes when you place patients on opioids for something that's a little bit more chronic in nature, muscular in nature, or inflammatory in nature, the narcotics are not going to be very helpful, especially if you're having more nerve-related symptoms. I kind of use this analogy. It's like taking a bazooka to a water gun fight. They're going to drown out the pain for sure, but you're not really treating the issue that's at hand. And if anything, you're going to lead the patient to having development of tolerance moving forward. And then other things, topical agents are helpful, provide, relief of pain more from a surface level and TENS unit. And so overall, how I think about management of pain from a medication standpoint is to try to use medications in all the classes so that you can get some relief from all of them. Tylenol, many patients say it doesn't help, but it probably is providing 10, 15, 20% of pain relief. The anti-inflammatories may provide another 10, 15% pain relief. But if you add everything up, the medications together may get you that 60, 70, 80% relief from the medications, which I would say is pretty significant. So you have to have that discussion with the patient, because a lot of times they are looking for one medication that's going to fix everything. And unfortunately, the one that typically gives them that relief is the narcotic. Once you've exhausted the conservative multimodal analgesia and physical therapy, this is kind of where I practice for the most part. My focus of my practice is interventional pain management. And what I mean by that is I try to take a look at what is the source of the pain and what kind of intervention can we do to try to go directly after that. Comes in various varieties: epidural injections, medial branch blocks, or to go after facet joints, radiofrequency ablation, SI joint injections, trigger point injections. We'll go over each of these briefly. So epidural steroid injections help treat patients who have disc herniations, foraminal stenosis, spinal stenosis. It's basically placing steroid at the nerve root level that was being compressed the most. There's different techniques, there's different approaches. There's the transforaminal route, where we're more selective at a nerve root on one side or both sides, versus the interlaminar route, which just allows our medications to spread usually up and down a few levels, as well as left and right. And so sometimes we will try one approach, and if patients get great relief, that's awesome. We let them ride with that relief. If they don't get that great relief, maybe we switch up our levels, or we switch our approach to get a better relief with the second injection. And the whole goal is basically to place steroid in the epidural space, which will help relieve some of the inflammation that is being caused by that disc herniation or that nerve root compression. And so these are just some examples. That was an interlaminar on the slide before. And this is a transforaminal epidural, where we're being more selective of a nerve root here on the right side at L3. The next thing is a diagnostic medial branch block. So like I said, very common to see patients with disc herniations, nerve root compression. But for those patients that have, in addition to that, inflammation of the lower joints, it's very difficult to treat something like this with surgery. If anything, placing hardware or having surgery is likely to worsen the inflammation you have at the joints in your lower back. And so a minimally invasive way to treat inflammation in the lower back is to numb up the nerves that provide sensation to that joint. So those are those medial branch nerves I mentioned earlier. And the way we do this is we actually do a series of 2 diagnostic blocks. We numb up those nerves with the short-acting local anesthetic, and we're looking for significant low back pain relief at the core in the first 4 to 6 hours. If the patients do get that on 2 subsequent diagnostic blocks, then they are a candidate for ablation, which I'll explain here in a second. But you can never reverse inflammation. It's there. You can do activity modifications, you can take medications to help treat the symptoms, but that inflammation is going to remain there. But you can do different things to help treat the symptoms that patients are experiencing from that. And so this is just a quick example of what a diagnostic block is. It's placing a needle right at that junction where that nerve exists, placing a local anesthetic and numbing up that nerve. And if you have relief, then you can do what we call a radiofrequency ablation. So we place electrodes via a needle in the same location we did for our test block, and we use heat to basically create a lesion, or what I would tell patients, we deaden the nerve. And this allows for that nerve to have reduction in its ability to send pain signals to the brain from that joint. Now, this doesn't mean that they will not have any sensation of pain in their back, or if they have another injury that they won't notice that they've injured their back. It just will help reduce the severity of the stiffness, the tightness, aching sensation that they're having on a day-to-day basis. Now, ablation that's done well and with a good success typically can provide reasonable pain relief for 6 months to a year, and the pain will likely come back. And the reason for that is that any nerve that you cut, ablate, manipulate does regenerate. And that's typically why you would have some of that pain come back. And if so, then the best treatment for that is, if it worked before, you go ahead and you repeat that ablation to give the patient relief for another 6 months to a year. It's very minimally invasive, not requiring any surgeries, all an outpatient procedure. So this is something that is, a very significant component of my practice. Now, a couple other targets. You have SI joint injections, similar concept. You're using steroids in the SI joint to try to reduce inflammation that's coming on from that area. And if you have relief, you can also do an ablation of this joint. Trigger point injection, something you can easily do in the office for patients who are having more muscular pain or myofascial pain. You try to release the inflammation by placing a small amount of steroid in the muscular bed itself. Now, beyond this, so these are more of the conservative interventional options that we have. But for some patients where you've tried these initial options and they're still not getting relief, the field of interventional pain has advanced quite a bit in the last decade and beyond, and we've developed various devices that can provide relief for patients that is still minimally invasive. So we've developed interspinous spacer devices, or Vertiflex, to treat spinal stenosis. Spinal cord stimulation or dorsal root ganglion stimulation has been used to treat a lot of different etiologies of low back pain. And then there's also the intrathecal pump or intrathecal drug delivery to treat cancer pain or post-laminectomy syndrome. So this is just a quick picture of what that interspinous spacer device is. The best way to explain this is, think of a car jack. You have compression of your spinal cord because there's not that much space. The various bones are getting closer to one another because the discs have degenerated or have bulged. This is a device you can place to kind of get in between those spinous processes, and you open it up to help open the space, and that, in essence, will decompress that area. The good thing about this device is that if it provides relief, that's great. You can get relief for lifelong, really, if it's really well placed. But if the symptoms come back, you can always refer the patient to have surgical intervention, and the surgeon, when they go in to do their laminectomy or their fusion, can just pop this device out. So it does not preclude patients from getting spine surgery in the future, but it may be a great option to either delay it or prevent it altogether. More recently, a procedure has come out where we are doing minimally invasive decompression. So that ligament that I mentioned before sometimes will become inflamed or will thicken and can cause spinal stenosis from the posterior aspect of that spinal column. And this is a device where you can go in and basically scrape off components of that ligament to try to help open up the spinal space. Again, minimally invasive. It's an outpatient procedure and can provide significant relief. And if symptoms return, again, no reason why this patient can't have a surgical evaluation and proceed with that. So you're not really limiting their ability to have other interventions in the future. Now, the next few slides are really some things that I have tried to target more for our patients who have that pain that's more difficult to treat, which is spinal cord stimulation. Best way to explain this is really think of a TENS unit. It's in essence a electrode that we place in the back aspect of your epidural space, and it helps scramble pain signals in the posterior aspect of your spinal cord, which is where all the sensory fibers really lay, and scramble those signals before they get to the brain. It's a very peripheral explanation of it, but it can provide significant relief of pain not only in the back, but also into the legs. And you can cover both areas pretty well depending on the different programs that you use. Now, there's various companies that have produced spinal cord stimulators. There's 4 major ones. This is just one from Abbott, who recently came out with the smallest implantable battery. Some of these batteries are rechargeable, some of them are not rechargeable. There's different programming. So there's a lot of different nuances as to why you would pick one device over the other, but at the end of the day, they're all delivering a device that delivers spinal cord stimulation. And this therapy has changed patients' lives. By stimulating that dorsal aspect of the spinal cord, you can get significant relief that you may not even get with different surgical interventions. Leading from that has been the dorsal root ganglion stimulation, which is a relatively newer modality. Rather than stimulating the entire spinal cord and getting coverage on both sides of the back and legs, now we have the ability to stimulate specific nerves or specific nerve distributions to go after various complaints. So this has allowed us to treat hip pain, pelvic pain, abdominal pain, in addition to complex regional pain syndrome, groin and testicular pain, etc. And this is kind of what that dorsal root ganglion stimulation electrodes would look like if placed in the lower two levels of your spine. And then the intrathecal drug delivery, for me, this is one of those options of, last resort, unless you have a patient who has like cancer pain. But it's a great option to deliver medications more in the spinal fluid itself, directly at the spinal cord. Also a great option for patients who are on a very high dose of narcotics, because you can really reduce the narcotic requirement by delivering medication at the source where they need to act, rather than impacting the entire body. So I'll wrap up here to kind of go over, go back to that initial conversation we were having, which is, what is my philosophy as an interventional pain physician? And for me, like I said, I like to try to use conservative modalities as much as possible, try to get patients back to their baseline function. But I'm not shy to use these interventional options that we have, because many times, coupled with multimodal analgesia, this allows patients to get that relief much faster and get to where they need to sooner than later. And when we look at back pain, like I'm sure you've seen, patients will have complaints that are originating from different sources. We have to realize that back pain does not just have one etiology, and you have to treat all the different generators to get full control of that pain. And so it's very common to go after the most pressing symptom with maybe an epidural or nerve-related medications, but then to follow that up with treatment of inflammation from the facet joints if it's still there and causing symptoms, or vice versa, or moving on to more advanced therapies if these initial interventions are not as effective. I'll leave this for you to review. I won't go into it in much detail, but this is just an overview of kind of what type of relief we're looking for with our various interventions. There's no intervention that's going to be 100% effective every time, and we understand that. But we know that it can provide some relief, and we want to continue to build on that relief. And so whenever pain physicians are seeing patients and making recommendations for further procedures, this may kind of give somewhat of an insight as to where we are coming from our recommendations and why we're looking to move on to a different procedure or a different intervention. So I'll leave you with this. At what point should you involve an interventional pain management specialist? And from my opinion, once a patient has done physical therapy and has maybe tried some of the conservative multimodal analgesia by a primary care doctor or an initial physician evaluation, a pain specialist should be your first line specialist. Many pain specialists are trained. They will evaluate imaging. If there's sudden need for surgery, they will refer that patient to a surgeon and get them there sooner. But many times there's a lot of things that we can do from a medication standpoint, from an interventional standpoint, that will either require the patient to never need surgery or potentially delay it until it's absolutely required. And like I said, all of us are looking forward to just work with the patient and to improve their functional capacity. And that's our main goal. I'll leave this for everyone to review. Obviously we focus our lecture today more on low back pain, but I see patients with various conditions, neck pain, spinal stenosis, major joints, SI joint, hip, knee, and shoulder, as well as complex nerve pain, so neuropathy, complex regional pain syndrome, foot and ankle surgery-related discomfort. And so I'm happy to, have another conversation at a later date to go over my evaluation or management, or what I think of how to manage some of these other conditions. But I'm happy to field any questions about low back pain today. Couple of the other interventions that I offer depending on the etiology, so you guys can take a look at this at your own time. And I'll leave you with this, with our contact information. Here I'm located out here in Elgin. I have a team here with Jason, Julie, and Lisa who help take care of the patients alongside myself. You feel free to give us a call or send us an email. I'm happy to chat with you and answer any questions that you have. But thank you for listening.
Perfect. Thank you very much. Great presentation. A lot of information. You didn't know you were going to drink from the fire hose today when it comes to low back pain. A lot of information. So thank you very much for that presentation. For more questions about workers' compensation, referrals, or to learn more about our Fast Track program for injured workers, please see our website at orthoillinois.com and click on Employers. In Algonquin, Elgin, McHenry, and the greater Chicagoland area, please call Paul Strandquist at 815-847-7088. Or in Rockford and North Central Illinois, you can call me, Bill Collar, at 815-847-7044. We've got a lot of great questions already, and we're coming right up here on 1 o'clock, so we're going to try and cram through as many of these as we can. Natalie asks, so what is your opinion, what percentage of low back pain is caused by facets as opposed to disc problems?
So it's challenging to really put a percentage on that. I think a lot of that has to really be evaluated based on the symptoms. I would say that in majority of the patients, there's a combination of both. It's just a matter of what symptom is present more initially and which one you want to attack first. A lot of times I have that conversation with patients that I think your pain right now is maybe more due to your nerve compression, so we're going to go ahead and address that. And you do have some facet inflammation, and that may be causing some low back pain that will linger. We'll treat that at a later time, or vice versa. Like, I don't think I can specifically put a percentage, but I would say a majority of patients have evidence of etiologies that will be coming from both of those places.
Great. I'm looking forward to your answer to this one because I think I might know. Rosalinda is asking, is the reason why we don't see discograms being done anymore to order and better define the pain generator when there is more than one level of spine involvement?
So discograms were used in the past, and I think they have fallen out of favor, like you've mentioned. I think a big component of that is that people will have discogenic related pain, but the process of doing that procedure actually opens the patient up to infection and unnecessary risk. You get some information on the fact that it may be this specific disc or whatnot, and there were some procedures that were done in the past to try to place various types of materials to help strengthen that disc and reduce inflammation and reduce pain coming from it. But from my perspective, I think placing a needle into a disc just for diagnostic purposes is opening up a patient to a risk that they don't necessarily need.
Got it. Jessica asks, so how would you treat a patient with an annular tear that has attempted oral pain medication and physical therapy, but continues to have severe pain? Hypothetically, of course.
So it depends. With an annular tear, really, that mainly means that casing where that disc was has now broken at some point, and that's causing some extrusion of the disc content. That can cause definitely, discomfort in the low back. If it's causing significant nerve compression, whether it's central spinal cord compression or lateral recess compression, probably would treat that with an epidural injection initially. And I would make sure that that patient is on some sort of nerve pain medication to see if we can get better control. And that's probably the place I would start first.
Got it. Now, typically, what do you see as the typical benefit to be expected from epidural injections or RFA procedures, and why are they so often recommended to be repeated early on in the treatment process?
That's a good question. So with epidural injections, we're looking for at least 50% improvement in the symptoms. And for the most part, an epidural injection is going to help nerve-related pain, which means, pain that's going into the lower extremities, and to some degree, the low back pain, especially from like a posterior annular tear, could help. Now, depending on at what point in the injury or recovery you're doing this, you may not get that 50% relief. And sometimes we may not be injecting at the right level. If you have multi-level etiology, you may need to do a few injections to figure out what level is going to be the most effective. So how I approach it with patients, I usually tell patients, if you come back with 70, 80% relief of your symptoms, then, I wouldn't recommend a repeat epidural injection, and we would just see how long that relief lasts, hoping that, for the most part, an epidural injection will provide at least 3 to 4 months, maybe longer relief. If you have less than that, somewhere between like 25 to 70% relief, that tells us that, we definitely are getting relief. It's just maybe a matter of the approach that we took, the level we injected, and we may need to adjust that on subsequent procedures. So that's commonly why pain physicians are recommending repeat epidurals, because we may not get the right level every time at this first injection, or maybe the approach is needed to be adjusted. But why physicians may recommend injections routinely is, like I mentioned, the relief often is there for about 3 to 4 months, sometimes longer. And that may seem as if it is short-lived, and it is, but if they're getting enough functional relief with these injections, and that's preventing them or we're not requiring them to have surgical intervention for their pain, then it's a much better option. It's a minimally invasive thing to undergo to get the pain relief that you need. Now, for diagnostic medial branch blocks and RFA, the typical relief from the diagnostic blocks, we're looking for 70-80% relief for somewhere in that first 4 to 6 hours. But if once you get to the ablation, our goal is to at least have 50% improvement in functional capacity or pain relief for at least 6 months to 12 months or longer. And like I said, the reason for why that pain likely will come back is that the nerves do regrow. And as mentioned before, the pain is not going to be 100% alleviated, but the severity or the frequency of the discomfort should definitely be reduced.
Great. I see that we're right at 1 o'clock. Do you have time for one more question before we go? Great. We've got a bunch of great ones, but one that we've got here I think is really appropriate. You talked about getting a pain management physician involved earlier in the process. How would you address those concerns about sending a patient to a pain specialist? Wouldn't that further delay surgical intervention?
That's a good question. And so how I would explain that to all of our colleagues here, especially the ones that are on the call, is that a pain management specialist, if you involve them in the care of patients earlier, there's a lot of interventional options that we can provide. And we also will be able to do a deep dive on what the imaging shows. If a patient needs surgery, we will refer them to a surgeon as soon as possible. But in many cases, we can provide functional relief with minimally invasive options, injections, different procedures. And we're able to catch these patients before they're placed on narcotic medications or abuse potential medications. And that is the biggest service that we can provide. I think that many times I see patients on the other end of the spectrum, and I wish I saw them at the beginning, because I may have prevented them from needing surgery. I may have prevented them from being on the narcotics that they're on, and their quality of life could have been much more improved than they are now. And I'm kind of working from behind, and we still get meaningful relief. But any patient, I would say, you have that has back pain, get through the conservative management, send them to a pain physician. They'll prescribe the conservative management themselves, but we will do everything we can to go after the source of the pain. And if we're not able to manage it, we will send them to a surgeon. I promise you that.
Got it. Dr. Shah, thank you so much for your presentation and all your hard work putting this stuff together and your time today. I want to let you get back to your patients. For everyone else, thank you for your time. Thanks for hanging with us just a little bit past 1 o'clock. You don't forget to fill out the survey that you should get in just a few seconds. And if you have any questions at all, please reach out to Paul or myself, or look on our website at orthoillinois.com.